or we plan to have a panel on requirements for training and personality of psychedelic therapists. And we would like to introduce or have them introduce our panelists. I think we'll later change to a question and answer style. We also have a long list of questions that you guys have handed in on Slido, so we'll not get bored, I think. So maybe I'll ask the two therapists in the middle first. Please introduce yourself briefly and tell the audience a little bit about your therapist training, where do you come from, what's the framework of your work as psychedelic therapists?
Okay, I'll start. So my name is Ingmar Gorman. My role is as a PI for one of the phase 3 sites in New York City for MDMA-assisted psychotherapy for post-traumatic stress disorder. So I'm also a therapist on that study. My background in terms of my orientation is primarily relational, psychoanalytic, psychodynamic, but I've also been trained in CBT and some mindfulness approaches. So in particular, one thing that I actually lean on a lot is integrative harm reduction psychotherapy that was developed by Andrew Tatarsky, which is an approach to deal primarily with, or to work with and help people who have substance use issues. So that's a perspective that integrates the previous models I mentioned, psychodynamic, cognitive behavioral, and mindfulness. And one other role that I have is as an integration therapist. So I work in private practice to help people who use psychedelics in various contexts, legal, not legal, on their own, at retreat, to help them in various ways, whether it's to prepare or to integrate.
Thank you, Ingmar.
Hi, I'm Elizabeth Nielsen. I'm a psychologist also based in New York. I work with Ingmar quite a lot, and I'll give a little of my therapeutic background first. So as a psychologist, my main interest was in working with empirically supported treatments for substance misuse or substance use disorders. I trained in harm reduction. I trained in mindfulness-based approaches. And also in integrative harm reduction psychotherapy with Andrew Tatarsky, just like Ingmar. And in psychedelic therapy, I've been involved in for about almost 5 years now. I have the distinction of having worked on the psilocybin-assisted treatment for alcohol use disorder study that's ongoing at NYU. I've trained in the MAPS protocol and am worked as a phase 2 and now phase 3 therapist in the MDMA-assisted treatment for post-traumatic stress disorder, ongoing work there. And I've also recently trained in and begun working on a phase 2 trial of psilocybin-assisted treatment for treatment-resistant depression that is just beginning in the United States, and that's sponsored by Compass Pathways and at the Columbia, New York site. I'm involved in therapist training and supervision, and outside of the clinical trials, work with Ingmar to help train therapists in harm reduction and integration work that they can do outside of actually being a psychedelic therapist, but working with people to actually prepare and reduce harms associated with and perhaps maximize benefit from psychedelic experiences had in other contexts.
Thank you, Elizabeth.
Yeah.
So we have two therapists involved in different studies with different backgrounds. Then we have two people that come from a different background. So while they are not the opposite of what we said here, they are not the healers, but they come with different perspectives on healing. So Vanja Palmas is a meditation teacher, mindfulness activist, and he's also involved in sponsoring psychedelic studies in Switzerland. Maybe, Vanja, you can say a few words about yourself and your relationship to therapy. Why are you interested? What's your relationship to therapy?
So my background is I'm an old hippie, and and a psychedelic experience brought me to meditation. And then I meditated quite intensively, and I did a sort of traditional training to become a Zen priest, and was totally abstinent drug-wise for 25 plus years. I didn't sort of green tea maybe, no psychoactive substances, but I knew I had to go and look back into it, and so we have sponsored a study at the center that I'm running is with psilocybin and within a 1 week meditation retreat. Like on the 4th day, half of them got a fairly high dose of psilocybin and half of them got placebo. And in some ways, of course, being a meditation teacher has very much a lot in common with being a therapist. So I see a lot of people in a personal interview, and they tell me about their lives, and I try to respond. And in some ways, like being a therapist, it takes several years to be trained. Well, it usually takes also quite a few years to become a meditation teacher or to see people in that way. So I see in many ways a similar position than a therapist, even though we don't call it that way.
So thank you, Vanja. So that is also opening one of the central dichotomies in therapy. So informal therapy, informal therapeutic effects maybe, and formal therapy. We'll talk about that in a second. Then we have Matthias Lichty, who has been giving a talk yesterday, and he was rather looking onto therapists from the perspective of a researcher, I guess. So what's your relationship to psychiatry and therapy?
So I'm not a psychiatrist or psychotherapist, but by training an MD with a specialty in internal medicine and clinical pharmacology. So we are developing medications. And regarding psychedelics, I am the legal sponsor, so that's the person responsible for trials, not the person with the pocket with a lot of money. That would be the financial sponsor. The legal sponsor for 2 clinical trials, one with patients with cancer and anxiety, and another one for patients with depression. So I have to discuss with the PIs of these studies what the requirements will be for the therapists responsible for these patients, or at least I have some responsibility, may have to answer to the regulator, the people who allow these studies to be done in Switzerland, what the requirements are for the actual physicians assisting or the psychologists assisting these patients. And the second domain where I'm in contact with the therapists or have some obligations or need to think about who will be able to do this, to perform such treatments is we provide, from the University of Basel, we provide the substances to the psychiatrists in Switzerland to be used in substance-assisted psychotherapy. Currently, this is MDMA and LSD. So the Federal Office of Public Health may ask us, there is a new applicant who wants to use MDMA, and to whom can we actually give this substance? Can anybody apply? Do they need to be physicians? Do they need to be psychologists? What's their formal training? So there are a few questions to be answered, and we do have some rules set up together with the Swiss Society for Psychedelic or Psycholytic Studies. So this is my involvement in this area.
So psychotherapy markers, let's call them, are regulated in different intensity. So Germany is very regulated. We have two main frameworks that will be paid by the health insurance. Other countries don't have that frame. So that is one background that people have to adapt to. And then another thing is, since the 1970s, it wasn't possible to legally be trained as a psychotherapist until the studies started. So a lot of people got into the field that may not have had legal, formal training. In how far is psychedelic therapy, conducting psychedelic therapy at all different from conducting another form of therapy? Let's start with that question. So do you need skills that are different when conducting this therapy? Who wants to start?
I mean, I can mention a few things. You know, I think that for the most part, being a psychedelic therapist is something that can build on an existing set of strong skills as a therapist. It's not a completely alien, foreign thing, and that many good therapists with with training and backgrounds in a variety of different modalities can learn what's supportive, what's necessary, what's needed to become to appropriately treat somebody using psychedelics. But there are some unique aspects and some unique skills. There are some specific considerations around safety. There are some specific considerations around informed consent and ethics and working with somebody while they're in this very intense alternative state of consciousness, and the responsibility that comes with that, the boundaries that come with that. And then there are other considerations, such as being prepared for the intensity of the therapeutic relationship, which is different, and often just anecdotally speaking to therapists that are doing this, can feel more intense or more just a more intense relationship than they may be used to from non-drug assisted psychotherapy. So those are just off the top of my head a few of the considerations, but I think that there are a lot of therapists with great existing skill sets that could really translate to this very well.
I think Elizabeth answered that pretty thoroughly. I would add just one is sort of working with sometimes intense affective states. So not everybody can work with, for example, with trauma, and trauma is a kind of affective state. So being aware of what that's like, what that's involved, what might be sort of a certain kind of, what may be potentially contra-therapeutic. Another thought is, well, I'm glad you mentioned the therapeutic relationship, because I think that I find that often at conferences like this, that's something that's kind of neglected. And of course, it depends on the person that you're working with, and also I think the substance that you're working with. I think to generalize, MDMA therapy with trauma tends to have a more of a relational component, and that can get very, very complex. And then maybe the last thing I would add is what is your idea of the mechanism of action? So what is your idea of how the treatment is working? And if there's a lot of conversation about the mystical experience or about intuition, and if that is your kind of working hypothesis of how the treatment works, then you should also be prepared as a therapist to not intervene or get in the way of that process. We have a tendency to like to talk or do things. As therapists, we want to be a component of that mechanism, and there are different ways we can do that, and that includes sometimes allowing the participant or the patient to arrive somewhere on their own.
We'll talk about formalizing training in a second, but when it comes to these basic therapist skills, what's the most important when it comes to psychedelic therapies? So which is it? Is it empathy, or is it what you talked about right now, being able to hold back and not do all the time? Something else?
Well, I think both of those are good examples. I don't necessarily think that there is a quintessential single factor, but I think those are two. I think the ability to also be mindful. We kind of joke around that it's good to have a meditation practice as a therapist, because sometimes you're sitting for 4 hours just being present, and not everybody can tolerate that. There was Rosalind had everyone's on their phone, and you can't do that. You have to be present for the other person, but just sit calmly and be with your own thoughts. and also a metacognitive, sort of mindful, reflective, whatever language you want to do, capacity, whatever language you want to use, that capacity I think is really, really important as a therapist.
So, do you think that in non-formalized setting, the same effects could happen as in formalized settings? So non-formalized, I would say it's not happening within the practice of a psychotherapist or a clinic, yeah.
Formalized versus not formalized settings. I can do it.
Go ahead.
Okay. We work in both settings. We work in the formal research setting, and then we don't administer psychedelics in a private practice, but we work with people who use psychedelics in an informal setting. And so the way that I like to think about it is that if you want to maximize a therapeutic outcome, you would want to do it in a formal setting. I think we have existence proof that people do heal or get better outside of that setting, but I don't have the data. Well, there is data that shows that people do improve when they're doing it on their own, but I would guess that the formal setting is more optimal for a psychotherapeutic, and I use that word very specifically in our Western cultural context. There may be, as this sort of panel kind of alludes to, other goals that may be more suited to a different context, spiritual, religious context.
So now comes the killer questions, also to the one to Vanja and Matthias Lichty. Do you think that psychedelic therapy should be conducted by psychiatrists only? Doctors, because it's giving a drug to people, and that's usually what psychiatrists do.
Well, I would clearly say no, it should not be restricted to doctors. Formal versus more or less not formal therapy. So, like one of the differences I can say between the Johns Hopkins studies that are clearly in a hospital and formalized, and compared to the study we did in Switzerland in a totally different setting, in a remote Zen temple out in nature, embedded in several days of sitting quietly and in silence. Well, so the dosage was the same. The mindset was slightly different, namely that those were all experienced meditators. And then the setting, of course, is totally different, whether you are in a comfortably decorated room in the 4th floor of a big hospital, has a totally different vibe than if you are out in nature and in a temple and beautiful surroundings. And not surprisingly, in some ways, like the higher dosages, about a third of the people had reported some more or less, disturbing either fear or confusion. They all did well and came back with it, but in our study, there was not a single one. Not one reported any significant fear or confusion states at the same dosage. So obviously, if you want to talk about optimizing the effect, it seems like, to me, a setting in that kind of specifically tuned, much more effective than to have it in a strictly therapeutic hospital setting.
Should only psychiatrists or medical doctors be able to provide the therapy? No. That's it. That's not what I was saying, but he might have reasons.
Yeah. So, besides from wishful planning and thinking, we have like a pilot setting in Switzerland in that MDMA and LSD is already being used in patients outside clinical studies. So we can look at who is doing this treatment, what are the requirements currently. And I must say a physician is involved at some point, which is typically when the indication for the treatment is made, plus only a physician can order the medication. So I cannot provide
order or apply the medication.
Order. So practically I'm only sending out medications to physicians because they're considered as medications, and a psychologist cannot, by law, at least in Switzerland, administer medications. However, and this is similar for delegated psychotherapy, the physician, a psychiatrist typically, but not necessarily, can then delegate the treatment to a psychologist. So in practice, a physician who is a psychiatrist or even a general practitioner with special knowledge gets the approval from the Swiss Federal Health Office to administer MDMA or LSD in a specific patient. The approval is for a specific patient. And the physician applies for this approval, and it needs to be a physician. He gets the treatment, but then he can either conduct the sessions himself. Typically, he would then be a psychiatrist, or at least he has, let's say, psychological knowledge to do this work. But no, we do not require any formal grades for this. Or he can have a team of psychologists who conduct this work.
Crucial questions, of course, would be, is the medical doctor present, or is he at least in approximate?
No, that's another important point. I mean, you can have we are administering a medication. It can increase blood pressure. It can, in theory, people may overheat on MDMA. It has never happened in a controlled setting, but blood temperatures go up, even in a controlled setting, up to 39 degrees Celsius. So a physician needs to be present. If not in the setting, but he has to be there within an hour or something. So there is a physician kind of having the responsibility or supervision for this session only medically. That has nothing to do with the psychology going on in the room. Rather, somebody needs to be there in case a benzodiazepine needs to be administered in a case of LSD-associated anxiety or whatever it is. And this has happened. We have administered medications, antipsychotics, or anxiolytics in such cases very rarely, but it has happened. And for this, you need a psychiatrist or a physician. The actual session, the thinking currently for us is that the session can be conducted by a non-physician, even a non-psychologist, if he has the proper training. There is no requirement, in our view, that these need to be like trained psychologists with a 4-year additional psychotherapy training. There is also debate about this. It's not that only the physicians and the, yeah.
There's a large debate about this. I mean, we're not in the rollout phase yet, nowhere. So when you go to rollout, of course, these questions need to be decided in each country, maybe internationally. So will this happen in treatment centers? Will there be an emergency doctor in a background service close to that? Will there be a psychiatrist having oversight over 8 or 16 psychologists? This is everything that has not been decided yet, and we don't know if it works. So what's your position on?
I just want to bring in the US situation, if I may. So, because we're talking about different contexts, and I think it's really important to disambiguate the difference between the research context and then the outside of research context, because those are different. And in the United States, actually, it's actually currently more clear about these questions within the research context under the FDA and the DEA. So I'm a psychologist. We have a Schedule I license holder. MDMA is a Schedule I drug, and he can deputize individuals to administer the MDMA. So the psychiatrist, the MD, the Schedule I license holder doesn't have to be present. I can access the drug myself, as well as the rescue medications if we need to provide it.
And is he responsible legally if you do something wrong?
It would be his license. So there's a lot of trust involved. But this is somewhat nice in the sense that it's clear, but what happens outside of research context is not known. And in the United States, it's actually more complicated because state by state, regulations can be different. In some states, psychologists can actually prescribe medication. And then there's a whole question of prescribing versus dispensing versus administrating, which are different things. So we have a lot more to still figure out. I think the hope is that psychotherapists will be able to, of course, provide the treatment. In other words, I think the goal for MAPS is there for it to be high quality of care and good regulation, but for it to not be too limited for who can actually provide the treatment.
So who should be able to provide the treatment in the future? Let's go to the future. Should it be the highest qualified people with a medical psychotherapist degree with a specialized training, or should we rather, or would you rather go for a system where a lot of people can do it, that only have further education?
I mean, I think that it depends a little bit also on the treatment population that you're talking about and what the patient or participant is there for.
But why so? If you're a usual therapist in a cognitive behavioral therapy, you might get a lot of patients with different indications.
Right, and some therapists have the training and expertise to treat much more complex cases than others. So there are many people for whom, there are people with more complex presentations that may require a therapist with a higher level of skill and training. And so I think we're going to need a variety of therapists with a variety of backgrounds, and that not all therapists will be fits for all patients in the future. And there's going to have to be a little bit of discretion there in terms of people finding a therapist that has not just the training in psychedelic therapy, but the training in actually working with the condition that they are presenting with. So, when we kind of just talk about, like, what does it take to provide psychedelic therapy, it's like, well, psychedelic therapy for what? And in what context and for what person. And I think we need therapists with a variety of backgrounds, a really diverse variety of backgrounds in different approaches to psychotherapy and in different levels of care.
For the treatment of alcohol, you need somebody with a specialization in addiction.
Precisely. And some people with a addiction history are going to need a therapist with other very specific qualities or specific expertise or more expertise. They may have medical complications. They may have personality complications. They may have a lot of other things that therapists would need a background in. So it's not just about being able to provide psychedelic therapy. It's about being able to provide adequate and good therapy.
So yeah, because the title of the panel is Therapists versus Healers. Healers actually usually don't have these qualifications and these specialized trainings. So do you think that will be that there will be a need at all for non-psychological and non-medical healers in the future? Will that market still grow like it seems to be in the future? Will the presence of that formalized therapy make this scene a little bit smaller? What's your speculation about that?
Well, I don't think everybody is going to need or want to have psychedelic-assisted therapy for treatment for a specific specific diagnosis or order. That's what we do. We're clinical psychologists. We work with people who are coming in with a problem that they want help with. Post-traumatic stress disorder, alcoholism, depression. So, if people are, seeking something for other, in another context or another means, they may not need to see somebody who is actually a therapist for that. A licensed, credentialed professional. I mean, there's a variety of needs and a variety of people that can meet those. And I guess I'm a little. The distinction between therapist and healer, maybe that's a semantics thing or a language idea, and if that's something that maybe you could say how you're defining or distinguishing that, that would maybe be helpful. But yeah.
So maybe another distinction. I mean, the substance-assisted therapy, as far as I understand, contains two components. It's the actual session, so you have an indication treatment with psychedelic substances in a session, and then you have the integration sessions, and you have the psychotherapy that goes on. So I could imagine a system where you have somebody in psychotherapy, and this should typically, if you have an alcohol disorder, ideally somebody with knowledge specifically in this disorder provides the psychotherapy. However, I could imagine that the substance session itself could be done by a non-psychiatrist and not even a psychotherapist, maybe even a healer, but maybe then the patient goes back for the integration session to the specialist. So the question would be for me, it's actually two different things. The overall therapy, yes, you need probably a psychotherapist to do good work here, and not a physician, rather a psychotherapist. It could be a psychiatrist or a psychologist. However, for the actual substance session, because the talking is usually not taking place during the session, but typically in the partly, maybe, yeah. On LSD at least, they don't talk as much. So maybe you can have a really good session with a healer or a non-professional, but somebody who has a professional experience or a high experience with this specific state. So we need maybe to separate who is responsible for the overall treatment, like the therapy part, integration, long-term treatment, and just the sessions. If this can be separated, that is also up to debate.
Could make a lot of sense. So the psychotherapeutic process would be a more complex, maybe also longer thing that could be handled by other persons than the sessions themselves. Well, let's come to the more difficult things when it comes to. We talked about training a little bit and maybe qualification. What about personality? In those of you living in Berlin or familiar with the German situation that know that in 2011, like 2 people died in an underground therapy, and the therapist had given 10 times the amount of the substance, which was MDMA, to those people, and he was himself under the influence of 50 micrograms of LSD. This guy was actually a doctor, but he was an underground therapist, and a lot of people were like investigating, was there a certain personality trait that could be, or a certain idea that could have been most responsible for things like that happens. I mean, some people say things like that, death in therapy happen in other disciplines too, and surgery, but we shouldn't play it down. So that's a drama, of course, if somebody is expecting healing and he or she dies. So do you think that things like that can be related to certain traits of people who are interested in psychedelic therapy?
I really want to say something about the previous question, if I may, just very briefly, that I think I support fully what you're saying, but also that it also depends on the indication, I think, and the therapy and the substance. MDMA can be tremendously interpersonal. It's not about the mystical experience. And sometimes the healing, particularly when people have been interpersonally traumatized, is in the relationship. It's in this fact that they can experience another person as trustworthy, as experience themselves as lovable. And that I think really needs to be carried over. So that's just my one. I think these aren't mutually exclusive, but we need to have options. In terms of the comment, I immediately feel a little bit of fear around this question, because the idea is that we're somehow going to be able to predict who is going to do what action, and it seems a little bit like dystopian in some way. There are people who are very narcissistic who are also seem to be really good therapists. I know it's sort of counterintuitive, but somehow they can sort of switch that part of themselves off, and then somehow, I should qualify it, not necessarily meeting criteria for a narcissistic personality disorder, but I think you could get into very dangerous territory when we begin to try to predict who, although we all can have a felt sense of maybe somebody who might not be appropriate for the work.
Well, there is also research about it. If you look at the Handbook of Psychotherapy Research, Behavioral Psychotherapy Research, Howitt and Olinsky, they've done like decades of research on personality traits. And like empathy, of course, would be something that is present in most therapists. If you don't have that, if you're very, very self-centered, it would be not very likely that you become a good therapist for a lot of people.
My answer to that question would be, I would rather it sort of be on the other end. In other words, and maybe we'll get to this later, but what are the consequences for somebody doing something that is inappropriate? You know, so rather than trying to necessarily, I mean, so hopefully psychotherapy training institutes are also they're selecting for people who are more appropriate to be therapists. But my point is that hopefully there will be a licensing body sometime in the future that can, for there to be consequences and dissuade people from doing such things that sort of like the example that you mentioned.
I wonder if that division between healer and therapist is not, to me, basically they're the same. And they're just different lineages of trying to help people with difficult emotional or problems. And in both traditions, it involves years of training under a competent healer or therapist or teacher. And so, in the clinical psychiatrist or psychologist, it's a clear curriculum, and you cannot shortcut it. You cannot get it in 6 months and then say I'm a therapist. Whereas in the more indigenous ways, of course, anybody can put a feather in their head and say I'm a healer. And there's not many people that can check that out. But in a traditional way, I mean, they have years of training and under supervision of the elder. And the same is true for religious training.
Of course, we've been talking about traditionalism already on the conference. Of course, in modern society, we don't have those traditional systems in place. There's a lot of new age coming and going, 20-year-olds trying to be a therapist, without any training. But I'd like to take the discussion a little bit to you, listening so far, and start with one question that you handed in Slido, a question that is always coming, and you know it, yeah? So it's an ethical question. So is a psychedelic therapist, does he have to have experience with a psychedelic substance in order to be a psychedelic therapist? Is that necessary?
I had, only 2 weeks ago, I was a weekend with Rick Doblin from MAPS, and to my great surprise, he said he doesn't really insist that everybody has. I was totally the other position, but he said it's not really a requirement for a psychedelic therapist to have had their own experience. I said, what? But that was his position.
I saw this one coming a couple of years ago and wrote a paper about it. It's a very, very complicated question. There is no simple answer. We're talking about a variety of substances.
Thank you for saying that, but some people believe it's very easy to answer.
Okay, well, you know, if you have a sense that it's a less easy question to answer at the end of this, then we'll be sort of happy to entertain more ambivalence. I mean, I think, you know, Rick's position is interesting. You know, MAPS does actually provide an opportunity for therapists in their training program to have a personal experience with MDMA, but it's not required. And there are many potential reasons why somebody wouldn't be able to do that. First of all, it is a research study that they are participating in order to have that experience. And you have to be able to meet all of the inclusion criteria and not meet any of the exclusion criteria to be in that study. And if you're familiar with the kinds of inclusion and exclusion criteria that one would need to meet in order to participate in a study, you'll realize it's quite a list of things. And not everybody who is you know, potentially an amazing psychedelic therapist is going to necessarily meet those specific study inclusion and exclusion criteria in order to do that particular piece of the experiential training. So that's one sort of aspect that we have to think about. You know, I think we we can talk about, in general, experience of and level of comfort with alternative states of consciousness, which I do believe is very important for therapists working with people in psychedelic states to have, in a broad sense. Where specifically that comes from is probably it's probably more a question of one's personal history and personal development, and I don't think we can necessarily dictate exactly what experiences are going to give someone that kind of familiarity with and comfort with alternative states of consciousness. Just because one's had a psychedelic experience and like checked off that box with specific substance X, Y, or Z does not mean that they have that level of comfort with those alternative states of consciousness. One may have a background of 10 years of meditation practice and be much more comfortable seeing someone through a psilocybin experience than they would if they had one psilocybin experience themselves. So it is really, I think, something that we can't necessarily draw some sort of specific line through and easily categorize. But that's just sort of my take on it, that it is a complex question, and we do need to think about it very carefully.
So thank you. I'd like to open it to the public. Can you put up the microphones? So what are your questions? I think first one, yeah. You can use a microphone. Use a microphone.
Thanks. So what's going on in Colorado currently?
Specific question. You know that there are also Swedes and people from Estonia and from South Africa in the conference.
Well, do you want to clarify what, I understand, I know what you mean, but do you maybe want to clarify for the...
Sure. I think it's 2 or 3 months ago, psilocybin became sort of semi-legal in the state of Colorado. So I imagine there's some kind of experiments or processes happening that might be able to guide the discussion.
Well, I mean, to my aware, I don't know what's going on there. You know, it's not. That doesn't necessarily mean that studies are happening, and it doesn't. I don't think there are for that reason. And there may be many people who are preparing to find kind of in the gray area, offering some sort of therapy, and so I think time will tell. But I don't really have a kind of a prediction around what direction it's going to take.
More questions. So it's really hard. A lot of people. So maybe you there? Yeah. You with a beard. Yeah.
Yeah. Hey. My question is, I guess there's a lot of concern around what it would be like once this kind of therapy would be legal, and what happens when people have difficult experiences, perhaps in a way that would be like really bad for them in the long run. And so I'm curious if you think that it makes sense to have kind of less guided therapy, and I guess in the future taking more risks in the way the research is done, so that we know how to better kind of deal with it when people have really difficult experiences once the substances are legal.
I can do it. Yeah. Okay.
Let's do it.
Well, this is what we do already. I'm not sure if I understand your question fully, but you're saying that maybe less guiding so that people have sort of more experiences that are kind of more spontaneous or natural or not natural or affected, so that then we can observe the consequences and then know how to work with them. Is that the question?
Sure, I can clarify. This is following a conversation I had with a colleague who's talking about how much, I guess, how good do the therapists need to be and how much they need to know about what the clients are going through. And so his argument was right now we need to have the best therapists doing this kind of research because we want to have the best results. And I was saying, I think maybe now is a good time to have the difficult experiences with clients, because then we have the research on it, and when it happens later in therapy, we know how to deal with it better.
That makes sense.
Was a statement. Okay.
I mean, it's true. Both of what you said. We do have probably the highest. You're going for like the highest bar of standards of training and safety as possible at this time, so that where the focus is on collecting the data and most of the studies for rescheduling. but certainly a wide variety of experiences will be helpful when training a wider variety of therapists in the future. Yeah.
Okay. Yep.
Okay, so I acknowledge that you're putting together like the optimal therapy plan here, and it's a little bit like asking what's the optimal car, and you might come to the conclusion that it's made out of carbon and has 500 horsepower because it's the fastest. But if you take criteria like affordability into account, how would that change your assessment?
Well, it's a major question, and I think it's being evaluated and taken into consideration. So, I mean, it sort of touches a little upon about what you were saying, that could it be somebody who facilitates a session that doesn't necessarily have to have a PhD or an MD? I mean, that definitely will affect cost. So, and again, maybe I think I'm speaking on behalf of MAPS to say that everything that they are doing is at cost. The training is at cost in order to make the treatment accessible, including financially. Yeah, I think we have to think very creatively, because you also don't want to. It's sort of, I don't want to name cars, but basically, like, you know, how much you want the treatment to still be effective and safe, so you don't want to reduce the cost too much, but on the other hand, not everybody can afford the most expensive treatment. Yeah.
So thank you. I have like 30 questions here, and you have like 50 questions in the audience, but this was what we could do today. I think it makes sense to maybe have another conference which is completely dedicated to that topic. There's a lot of interest in that. I'd like to close the panel with possibly very brief statements from everybody here. Could you give us an idea what's the minimal formal requirement that you would like a psychedelic therapist to have, and what's a minimal what's the most important trait that you think that a therapist should have? So formal and trait. Yeah, could you start, Vanja?
I would say loving care and attention is the universal remedy. So if you bring that.
You're a tough act to follow. I mean, I think that the requirements of a therapist are going to need to vary based on the treatment population, just as they do now, level of care that's needed and intensity of treatment. And I do think that for working with in the mental health field, having a background in mental health is going to be necessary and should be. Yeah.
Thank you.
I would say if we're talking about psychotherapy, I think a license is really important, because it's a built-in way of determining who can practice and who cannot. And then I think as a trait, compassion and love is important.
So indication of treatment by physicians, overall treatment by psychotherapists or psychiatrists, but session guiding could be by any special trained persons without formal degrees, and trait of the guy doing the session, empathy.
So thank you to the panel.